We are live. Dr. We are live.
So should I start now?
Yes, please.
Good evening, afternoon. Good afternoon, everybody. A very warm welcome to today's webinar. We're really glad to have each and every one of you all in this webinar. So today's topic is something everybody, even a vet and a student, can relate to, even in the practice, in field, in the education purpose. So looking forward to it. My name is Nonkit Lepcha, currently pursuing BVSc and AH, and an intern at West Bengal University of Animal and Fishery Sciences. It is my privilege to be the moderator for today's webinar, hoping that everything runs smoothly. So today's webinar is on the topic, Pet Eye Anatomy Basics and Emergency Ophthalmic Care. This is conducted by Entod Pharmacy. Now, I have the privilege and the pleasure to introduce our dear speaker, Dr. Sameer Chetri. Currently, he is serving as an Assistant Director in Animal Resources Developmental Department, Government of West Bengal, Darjeeling. He has completed his Bachelor's in Veterinary Science and MBSc degree in Preventive Veterinary Medicine from WBUAFS Kolkata. He hails from the Darjeeling Hills regions of North Bengal, and he has been a dedicated pet practitioner since 2011. Alongside his professional work, he actively volunteers in animal vaccination camps, sterilization, animal birth control programs, and many others. Sir brings a lot of practical experiences and dedication towards animal welfare, safety, and we're very glad to have him today, sir. Now, I would like to introduce uh, to our esteemed panelists for today. First, we have Dr. Deo Prakash Pandey. He comes from Kalimpong, West Bengal. He holds a BVSc and MVSc degree from WBUAFS itself. Currently, he is the veterinarian in charge at Kalimpong Animal Shelter. With 23 years of service and experience, he's performed thousands of surgeries from animal birth control to soft tissues, operations, and many more. He also runs his own clinic in Kalimpong, and he covers both small and as well as large animals. We're very privileged to have you, sir. And lastly, we have Dr. Sudena Bhutia. She comes from Korshong, North Bengal. She holds a BVSc and MBSc degree in veterinary surgery from WBUAFS Kolkata itself, and she's currently posted as a veterinary officer at State Animal Health Center, Korshong. With 9 years of dedicated service, she's been a key part of rabies-free Darjeeling mission, not just through vaccination, sterilization, but she also takes awareness camps to schools, colleges, and self-help groups. So we warmly welcome to all the speakers and the panelists and all the audiences in today's webinar. And as it is a very interactive session, I would like the audiences to keep a track to what the speaker and as well as the panelists says, so that later on they can jot down their comments in the section below. Now, moving on, as this comes to an end for the introductory part, I would like, with great respect, invite Dr. Sameer Chetri, the speaker for today, to take over the session.
Thank you, Dr. Nankit. Am I audible?
Yes, sir.
Thank you. So now I'm sharing the screen. This will take some time. Is my screen visible? The slides visible?
Yes, sir. Yes, sir.
Okay, hello everyone. This is Dr. Sameer Chetri, and thank you, Dr. Nankit, for introducing me. So today we will be talking about the basics of pet eye anatomy and emergencies in pet ophthalmology. So, starting with why ophthalmology is important in small animal practice. As we all know, we see a lot of eye emergency cases in pets, but most of these emergency cases are ignored. So, first is when we talk about the importance of ophthalmology in small animal practice, is protecting the quality of life, because the vision is very, very important, as animals, they relate to the navigation and social interaction, and also avoiding danger. So it's very important that their eye is of optimum health. Secondly is eye as a window to health, that it helps in detecting many systemic health problems, like we all see in cataract, that in diabetes mellitus we see that like there is cataract condition. So like as such we see many like health issues, and through the eye only, like we will be able to determine many systemic health problem. And also there are different breed specific congenital breed specific as well as congenital eye infections or eye problems. Talking about breed specific, we all know brachycephalic dogs, pugs. We all know pugs and Pekingese. They are all like more prone to the eye injury, corneal ulcer, dry eye situation like that. And also sometimes there is some congenital hereditary issues which we tend to ignore. So it's very important that all these are bring into the picture and taken to the vet as soon as possible. So now learning objectives, understanding the basic pet eye anatomy, recognizing common ophthalmic emergencies, and learning first aid management and referral guidelines. So we all know this part overview of pet eye anatomy, just a kind of a refresher. Orbit, we will be talking about in today's session: orbit, the muscles of the eyeball, lacrimal apparatus, external structures, mainly eyelids, conjunctiva, third eyelid, cornea and sclera, which forms the fibrous portion, uveal tract, which forms the vascular portion of the eye, and of course, the very important lens, vitreous, and retina. So, talking about dog eye anatomy and cat's eye anatomy, there is like a difference which will be of some interest for the vets practicing in the field. So, if you talk about dog's eye, uh, oh, I'm so sorry. There has been a slight mistake in the name. There has been a slight mistake. Instead of dogs, let me just make a small correction on this. I'm sorry for this. Dr. Nonkit, like the slide is okay?
Yes, sir. So there is,
Okay.
yes, sir.
So
It's
there
clear.
was an error. I'm so sorry for that. So if you talk, like if you see at a cat's eye and dog's eye, there is a difference, particularly in pupil. We see there is in cat's eye, there's a slit shape that can open wide in low light, which is very contrary to the dog's eye, which is round pupil, and it's better suited for the daylight vision. When we look at retina, there is more of rod cells, which is of more use for the animal to for the night vision or dim light vision, compared to the dog's eye, which is having more balance of rod and cone cells. And also in cat's eye, we see tapetum lucidum, which is attached with the choroid part, and that helps in the better vision. That is the reflective layer, helps in the better vision in the dim light. When we're talking about the field of vision, it's wider view in case of cat's eye compared to the narrow view in case of dog's eye. In color perception in both the animals, it's almost the same, but in case of dog's eye, it's more of dichromatic. So if when we talk about who has better eye, so in this situation, like in both the animals, they have their own respective adaptation with the with the light condition. For example, if you see a cat's eye, then it's like more used to or more efficient or more effective in low light conditions, making them as a predator in dim light. And if you see the dog's eye, then they are like more of a versatile vision suited for their social and active lifestyles. So now talking about the three, the different portions of the eye, we can divide it into three main layers, as I said earlier. The first one is the fibrous tunic, which holds the which holds the cornea and sclera. These are collagenous in nature, and it protects the eye's internal structure, giving the eye its shape. The second one is the highly vascularized and often heavily pigmented uveal tract, which is also known as tunica vasculosa oculi. It's composed of iris, ciliary body, and choroid. So this portion of the eye, this portion of this layer of the eye actually nourishes the interior of the eye and controls the amount of light reaching retina, and also helps in adjusting the focal power of lenses. And the innermost and the most important tunica nervosa oculi, consisting of retina and optic nerve. These form the neuroectodermal or inner layer, contains light sensitive receptor cells, which is this is the extension or the extension of the brain, which remains connected by the optic nerve. So now talking about the orbit, this is the main portion of the eye which gives the shape and helps in the protection of the eyeball. Its cone-shaped cavity on the lateral surface of the skull. It holds the eyeball and the structures that protect and move the eyeball, like orbital fascia, the ocular muscles, the eyelids, the tunica conjunctiva, and the lacrimal apparatus. These orbit its open type in predator species. It's like anteriorly placed, giving it a binocular vision in dogs and cats. Whereas we see in primates, horses, cattle, and sheep, they are more laterally placed, giving it a panoramic vision. The muscles of the eye, when we look at the muscles of the eye, um, these are just attached posterior, like at the back of the eyeball, which helps in controlling the movement of the globe. So these muscles originate in the vicinity of the optic foramen at the apex of the orbital cone, also known as annulus of Jin, which tends to encircle the orbital foramen and finally is inserted into the globe. So there are like four rectus muscle. There's a dorsal, which helps in the elevation of the globe. There is a middle rectus muscle, which helps the globe to turn nasally. There's a ventral rectus muscle, which helps the globe to move downward. There's a lateral rectus muscle, the name itself says, which helps the globe to turn temporarily towards the temporal side of the globe. And there are two obliquous muscle, that is the superior dorsal and inferior ventral. So the superior dorsal muscle, it helps the globe to rotate um, in a 12 o'clock position, but nasally. Whereas the inferior ventral, it helps to rotate the globe temporarily in 12 o'clock position. And there is finally a retractor muscle, which helps in the retraction of the globe. It's because of the problem. Sometimes we see there is a problem with the retractor muscle, because of which there is the protrusion of the third eyelid or the third eye gland. So now coming to the lacrimal apparatus, we see this is the very important portion of the eye because it helps in the drainage and providing the nutrition protection of the corneal layer. So it consists of the lacrimal gland proper, the glands that are associated with the third eyelid, several small accessory glands, and a duct system that conveys the lacrimal fluid into the nasal cavity for evaporation. The lacrimal gland is flat and lies between the eyeball and the dorsal ventral wall of the orbit. It's functionally divided into three main systems. So lacrimal apparatus has three main systems, that is secretory, distribution, and drainage. So when we talk about secretory, there are different in the lacrimal apparatus. It produces a tear films from the different glands. There are numerous glands within the lacrimal apparatus, like orbital, nictine, mebane or tarsal, Gis or more glands. So all these glands, it helps in the formation of the tear film. And the second one is the distribution. So distribution system, it helps in the spread of the tear film along the cornea and the conjunctival surface, making it like smooth. Whenever there's a blinking, there is there is a dispersion of this tear film throughout the cornea, making it all time hydrated and providing the nutrition, and also protecting it from any kind of infection or the foreign body entering the eye. And last one is the drainage. Drainage is the production of the tear that is drained through the lacrimal puncta into the through the lacrimal duct into the nasal punctum. Sometimes there is a problem with the in the lacrimal puncta region, because of which there is overflow of the tear all the time. That is called epiphora. So that needs an immediate surgical correction. Now coming to the eyelid and the conjunctiva. So eyelids, palpebrae, also known as palpebrae, are two muscular fibrous folds of which the upper is the more extensive and more mobile. Eyelids consist of three layers: skin, that is epidermis and dermis, a middle muscular fibrous layer, is skeletal muscles that is responsible for blinking, and also the fibrous portion, that is the tarsal plate, giving it the structural rigidity, and the mucous membrane known as palpebral conjunctiva, which forms the posterior surface of the eyelid, and it's thin and transparent. In the bulbar conjunctiva, it's the continuity of the palpebral conjunctiva to continue on the sclera. So there is a goblet cell, the conjunctival goblet cells, that contributes to the mucin layer of the tear film, which is quite important in the protection of the cornea and also safeguard of the eyeball. Conjunctiva is the most exposed mucous membrane of the body. So, like I said, tear film, it coats and nourishes cornea, is also an essential protective and nutrition layer of the conjunctiva. Excuse me. Now coming to the third eyelid or nictitating membrane, they are mobile, protective and glandular surface. It develops from the maxillary process. The third eyelid, it consists of the T-shaped cartilaginous skeleton that provides rigidity to the gland or to the lid. The gland of the third eyelid is present, which helps in the production of of the 50% of the aqueous tear film. Conjunctiva covering its bulbar and anterior faces. Stromal connective tissues. Numerous superficial lymphoid follicles under the bulbar surface. Goblet cells mostly on the palpebral side. So what is the function of the third eyelid? It helps in the distribution of the precorneal tear film, distribution of the precorneal tear film, protection of cornea, production of immunoglobulin of the tear film, and parts of its aqueous components. Now, what happens if we remove third eyelid? We see like there is a lot of cases when there is a protrusion of the third eyelid, often termed as cherry eye. So we do a lot of time we do pocket surgery, like putting the third eyelid back into its position. But sometimes, because of the histologically confirmed malignant neoplasia found in the third eyelid, or like there is some irreparable trauma, we are bound to remove the vets are bound to remove the third eyelid. So what happens when the third eyelid is removed? So there is a defective tear film production, and also there is just the function of the third eyelid is the protection of cornea. The cornea is affected badly. It becomes dry. So in chronic situation, in the long term, KCS, that is keratoconjunctivitis seccae, it occurs, which is not treated with any medication. Also, there is a keratitis and conjunctivitis, which is also not treated by any kind of medicine. So third eyelid is only removed when there is the histologically confirmed malignant cases, or there is severe trauma of the third eyelid. In these cases they are removed, but normally they are not removed. They are put it back through the pocket surgery. to its original position. Now coming to the cornea and sclera. So cornea is the main portion of the eye which faces the environment. It's the outer fibrous coat of the eye. It's the anterior transparent portion, and sclera is the fibrous coat of the eye. So sclera, it forms the majority of the fibrous portion of the eye, whereas cornea, it forms the 1/3 of the portion of the sclera. So these two, along with the bulbar conjunctiva, they merge in limbus. So like I said, sclera, greater portion of the fibrous coat of the eye, then does the cornea. So sclera is composed of 3 layers: episclera, sclera proper or sclera stroma, lamina fusca. Lamina sebosa is a sieve-like perforation of the sclera from where optic nerve leaves the eye. Similarly, cornea is composed of 4 layers: it's stratified epithelium and its basement membrane, collagenous stroma, Descendants membrane, basement membrane of endothelium, and endothelium. So stratified epithelium and its basement membrane, it's like the position is from outside towards inside. Also, from outside to inner portion. That is from the outer portion to inner portion. So outermost portion is your stratified epithelium and its basement membrane. Then comes your collagenous stroma. Then comes your Descendants membrane, basement membrane of the endothelium, and then finally comes the endothelium. So this is all about the cornea. So cornea, it has a remarkable feature of, it's a smooth optical surface. There is a lack of keratinization, there is a lack of blood vessels or any other pigments, and it's very sensitive. It's very sensitive. So whenever any the nerve supply to the cornea, it's very high compared to the skin. So it's very sensitive portion of the eye. And because of its unique structure, like smooth optical surface, relatively low density, and it maintains its relatively dehydrated state, and there is a rearrangement of the stromal collagen fibrils. So cornea is avascular. So the oxygen and the nutrients are obtained from the aqueous humor. The nutrients and oxygen, they are derived from the aqueous humor and also from the precorneal tear film. Now the next is uvea. It plays an important role in ocular physiology. So iris is suspended between cornea and lenses. It controls the amount of light entering the eye by varying the size of the pupil. Ciliary body, it alters the focal power of the lenses. Smooth ciliary muscle between ciliary body and the sclera. It produces aqueous humor that supplies nutrition to the ocular structures and aids in regulating intraocular pressure. Together, they also form a blood aqueous barrier to maintain the clarity of the aqueous humor in the vitreous. And choroid is a major role in providing nutrition to retina, and it is extremely vascular. Tapetum lucidum is the light reflecting area of choroid, and tapetum fibrosum in herbivores, found in herbivores, and tapetum cellulosum in carnivores. So the difference between the herbivores and carnivores is that in herbivores it's like more of fibrous type. That's why the term tapetum fibrosum. Whereas in carnivores it's a cellulosum, giving it the bright, distinct, reflective vision to the eye during the night. When the eye of a dog is being viewed in the dim light or in the night, then there is the reflection of the eye. That is nothing but the due to the presence of the tapetum cellulosum in dogs. Now lens is a transparent or vascular biconvex body. So anteriorly, lenses is in touch with the aqueous humor, and in the posterior portion there is a vitreous body. It's a solid structure through sufficiently elastic to be able to change in shape. It's been supported by lens zonules or suspensory ligament collagenous fiber that attach to the process of the ciliary body. The capsule of the lens is elastic and is permanently under tension. Owing to its elastic properties, the cortex can be molded so that the lens changes shape during accommodation. Now, the vitreous is the transparent elastic hydrogel. It occupies approximately 80% of the volume of the canine eye. It's a complex gel with constituents like water 99%, collagen fibers, the cells, this is also known as halocytes, and mucopolysaccharides and hyaluronic acid. So vitreous gel, it maintains the ocular volume, the shape of the globe, and maintains ocular structure, notably the lenses and retina in their correct location. It serves as a site for the retinal metabolism and lenticular and retinal waste products, thereby protecting all these vital tissues from these harmful waste products. There is no role in reflection of light because refractive index is almost same as lens. Now, retina, it's a 3 neuron sensory unit because photoreceptors relay the visual signs to bipolar cells and onto the retinal ganglion cells. So histologically, it has 10 layers. Layers 1 to 5 is called outer retina. They're adjacent to the choroid and outer tunica of the eye. Layers 6 to 10, it's the inner retina. They are adjacent to the vitreous. They are adjacent to the vitreous. It's the most metabolically active tissue in the body, as indicated by its high oxygen consumption. So we see it's a 3 sensory unit, and there is histologically 10 layers, because out of which like 1 to 5 is considered to be like the outer tunica of the eye. They are adjacent to the choroid and outer tunica of the eye, and the inner 6 to 10 inner layers are the inner retina. They are adjacent to the vitreous. So this is a quick refresher of the ocular physiology. Vision pathways in pets. Act of seeing the light falling from outside to the retina. It's been focused by retina, and it converts the photic energy into the electrical signal. That is the segregation of this retinal signals into various categories. That is brightness, motion, location, and orientation. There is a further processing of this information by the brain's visual cortex, the selection of relevant portions of the image for conscious attention and further action. And there are many reflexes. Then, like most of the time, we see whenever a pet is taken to a vet for an eye checkup, for an ophthalmic checkup, then these normal reflexes are usually done by a vet. There is pupillary light reflex. There's the position or the movement or the changes of the state of pupil during illumination and while in the normal state. There's a Menin's response, in which the animal is thoroughly checked without touching the eye, just by the movement of the hand. The response through the response we detect the condition of the eye. This is and the other one is the dazzle reflex. This one is the response of the eye to the bright light. Dazzle reflex. And also palpable reflex are there. There are some more reflexes like palpable reflex, tonic reflex, and corneal reflexes also, normally done by a vet during the eye examination of a pet. So now coming to the emergencies in pet ophthalmology. What constitutes an eye emergency? Whenever there is rapid vision loss, there is severe pain, redness, or structural damage, or corneal perforation. These requires emergency in pet ophthalmology. Now, the first one is the proptosis of the globe. So the globe, whenever there is the damage of a globe, the replacement of the globe should be done as soon as possible without any delay. If, however, treatment is delayed, then the owner should be advised to keep the eye moist with saline water, petroleum jelly, or antibiotic ointment. So careful examination for any systemic injuries are provided and provide appropriate supportive care, because most of the time what we see is like whenever there is road traffic accident in pets, and they are like taken to a clinic, then we only tend to check the eye and this is the only portion where we focus. But there are also other underlying life-threatening conditions which we tend to ignore. So all those problems need to be checked thoroughly. And the animal should be checked thoroughly, and not just the globe. And of course, globe has to be replaced as soon as possible without any delay. So what are the factors to consider while treating proptosis? Abrasion of the extraocular muscles, hyphema, there is a huge hemorrhage, or the condition of the pupils, and the skull conformation, whenever there is any fracture or any facial fracture or any damage on the skull, that has to be assessed thoroughly. So the favorable prognosis, it depends on in certain animals, like in brachycephalic dogs, the prognosis is favorable because it's quite common. Proptosis or the bulging out of the eye is quite common in these dogs. But again, like if you see in mesocephalic or doicocephalic dogs, then and there is no vision, there is no reflexes, then it's better to remove it is better to go with the enucleation or the removal of the eyeball. In cats also similarly, if there is a proptosis, then most of the time the condition is not favorable. But we need to also check whenever we see a proptosis case, then we need to check the reflexes of the animal. If there is a consensual pupillary PLR, or there is the vision is intact, then it's always a favorable. But like I said, it's unfavorable whenever there is the loss of the vision, there's hyphema, whenever there is a facial paralysis, facial fracture, or in non brachycephalic dogs, the condition is not so favorable. Now coming to the severe ocular and adnexal contusion and concussion. So injuries may be closed. That is, the corneal scleral cell is intact, but there is intraocular damage. And injuries may be open. There is the presence of full thickness wound of the corneal scleral cell. So what are the common clinical signs associated with the corneal trauma, ocular trauma? We say it's ocular pain, visual defects, abnormalities of one or more ocular or periocular tissues. So severe ocular and adnexal contusion and concussion. So what are the parts of eye that are affected? So first, coming to the orbit, whenever there is the fracture or there is a proptosis, then we can conclude that there has been trauma, severe ocular contusion, concussion. In case of eyelids, we see there is a laceration, there is a hemorrhage. In conjunctiva, we see there is a hemorrhage, there is a laceration. The iris or the pupil, there is no movement of the iris or the pupil because of the trauma. The lenses, there is the luxation of lenses. There is a deposition of the fibrin in the aqueous humor. In the vitreous gel, we see there is a hemorrhage, or there is the outflow of the vitreous gel into the anterior chamber. Retina, there is the retinal detachment, or there is hemorrhage. There is the damage of the optic nerve, and also neurological defects. There is the paralysis of the animal because of the head concussion. The animal is not able to move the eye, so there's a loss of vision also. So what are the emergency treatments we can do in such situation? So first of all, general examination should be done and the treatment of life-threatening disorders. So assessing of the neuro-ophthalmic reflexes, performing tonometry to check the IOP and a Schirmer tear test if possible. In certain cases, we need to sedate the animal so as to palpate the orbital rim and the facial bone. Radiography also may be done in extreme cases. Careful examination of the cornea with the magnifying loupe, and also do sidal test whether there is the leakage of the content from the cornea with fluorescent stain to check any defect. Perform ophthalmoscopy to check lens position, hemorrhages in the vitreous or the retinal detachment, and providing an appropriate medicines. And also animal needs to be given complete cage rest and examined at least at 4 hours interval. When the situation is out of control, like there is a massive damage, then it has to be referred to the specialist without any delay. The third emergency, ophthalmic emergency we often see in pets is the penetrating or the perforating injuries of the globe. So penetrating wound is a single full thickness wound of the corneal scleral cell without any exit wound. So there is just a penetration, but there is no exit of the wound. It's attributable to sharp trauma. Perforating wound has entry and exit wounds of the corneal scleral cell, and perforating wound has poorer prognosis compared to the penetrating wound. So how to handle when such emergency arises? It's to obtain a thorough history of the case of trauma. Always try to provide support to provide e-collar so that there is no further self mutilation. Administration of the tranquilizers and analgesic to calm down the animal. Avoid all pressure on the eye and the periorbital area. Carefully examine the eye to evaluate the extent of the injuries, and administration of medication as per requirement. Lid laceration. This is also quite often seen in pets. So what are the factors that determines the treatment of lid laceration? Time singe injury, which affects extent of bacterial contamination and wound cicatrization. Involvement of the lid margin and especially lacrimal puncta and caniliculi. Extent of lesion, whether the laceration crosses the lid margin. So things to take care of while handling lid lacerations, eyelid laceration, is to preserve as much lid tissue as possible. There should be minimal debridement and avoid self trauma. For that, we need to always keep animal under observation, providing Elizabeth collar and sedation and analgesic as per requirement. So you can see on the left side of the screen there is a complete laceration, and that has been corrected by a surgery with the simple interrupted suture in the dermis. So while suturing the lacerated eyelids, the things that we need to take care of is that the suture should not penetrate the conjunctiva. Otherwise, there will be the continuous irritation with the corneal eyeball, with the cornea, resulting into the further complications. Corneal ulceration and desmetocele. So whenever the situation arises or whenever these cases comes to the clinic, we usually perform a shimmer tear test if the cornea structure is stable, and then we go with the fluorescent stain. And if there is the facility to go with the cytological examination, then it's always good. Then we need to initiate antibiotic therapy on the basis of the cytological reports. Topical atropine to relax iris and ease the spasm. Desmocytol is a severe deep corneal ulcer where epithelium and stroma have been lost, exposing the membrane. So this needs to be referred to the veterinarian, to the veterinary ophthalmologist in case of like whenever there is a deep corneal ulcer. Corneal laceration, another ophthalmic emergency seen in pets, commonly seen in pets. So for this also, thorough examination has to be made. Sedation of the animal to prevent further damage to the eye and allow close examination. We need to make necessary arrangement to avoid self-trauma, avoid pressure on the globe and ocular adnexa, performing the CDL test to examine cornea and administer necessary medicines. So on the like in the picture, you can see there's a large full thickness corneal laceration, and also there is a moderate perilesional edema in the central cornea of the right eye of a cat. This one is of a right eye of a cat. So glaucoma. Glaucoma is very commonly seen in pet practicing. Intraocular pressure too high to permit optic nerve and retina to function normally. So whenever there is the intraocular pressure, it goes beyond. For dogs, it's 8 to 25 mm of Hg. So if it goes beyond that, then glaucoma it develops. So what are the characteristic changes we see during glaucoma? There's a disrupted exoplasmic flow in the optic nerve head. There's a death of the retinal ganglion cells, and their axons. There's a cupping of the optic disc. There's a visual impairment or blindness. So aqueous exits the eye via two main routes. Normally, in normal situation, the aqueous humor it exits the eye via through two main routes. That is the conventional trabecular meshwork route and the unconventional uveoscleral route. So whenever there is disruption in the production in this process, that is the production of the aqueous humor and the outflow of the aqueous humor, then mm, glaucoma glaucoma starts developing slowly. So so talking about the emergency glaucoma condition, this primary angle closure glaucoma with potential vision. So in this we will be using prostaglandin analog like latanoprost, or hyposmotic solution like mannitol, carbonic anhydrase inhibitor, and dexamethasone. So latanoprost, we all know It opens. It has a role in. It opens the uveo-scleral flow of the aqueous humor by acting on the ciliary body. Mannitol, because of its hyperosmotic property, it helps in the reduction of the intraocular pressure. But since there is the blood ocular barrier, sometimes mannitol is not able to enter, because of which it's not so effective. But again, looking at the property, other property like mannitol, it helps in the dehydration of the, or the sinking, we call sinking of the vitreous gel. That helps in, again, in the management of the intraocular pressure. This carbonic anhydrase inhibitor. Carbonic anhydrase, we all know this enzyme is present in the ciliary body, that helps in the production of the aqueous humor. So whenever there's blockage in the outflow of the aqueous humor, but whenever there's a blockage of the outflow of the aqueous humor, this CAI, carbonic anhydrase inhibitor, will act on this ciliary body, resulting in the stoppage of the production of the aqueous humor, thus controlling the intraocular pressure. Uveitis induced glaucoma. So we usually use dexamethasone and CAI, carbonic anhydrase inhibitor, along with the beta blockers or beta antagonist like tilmilol. Beta blockers, they play a vital role in decreasing the frequency of use of carbonic anhydrase. In uveitis induced glaucoma, we need to avoid pilocarpine, latanoprost, and systemic hyperosmotics like mannitol, because this will because these medicine will further lead to the increase in the intraocular pressure. Hyphema associated glaucoma, in this situation we'll be using dexamethasone topically, and also CI, a carbonic anhydrase inhibitor, with along with beta blockers. We need to avoid systemic hypoosmotics whenever we see hyphema associated glaucoma. Lens luxation associated glaucoma, in this situation we'll be using dexamethasone and tropicamide. Tropicamide, it helps in the dilation of the pupil, so that helps in relieving the glaucoma. But if it's not effective, then we have to switch over to the use of hypoosmotics or carbonic anhydrase inhibitors. And in this situation, latanoprost or pilocarpine or tilmilol should be avoided, because these medicines will lead to the constriction of the pupil, that will further aggravate, or that will further worsen the situation. So we have to avoid these medicines in lens luxation associated glaucoma. So glaucoma, surgical therapy for glaucoma. Nowadays we see, whenever the animal is in, like most of the time, the animal comes to the clinic in advanced stage of glaucoma, where medicine sometimes becomes not so effective. So in that situation, we usually go for the surgical therapy. And with this, we have two processes. One is the surgery that helps to increase aqueous humor outflow, and the commonly used technique is gonio implants. This helps in the outflow of the aqueous humor. And the other one is the reduction to the reduction of the aqueous humor production. So in this surgery, we go for this cyclocryotherapy. Cyclocryotherapy means, like, there is the use of the liquid nitrogen, the cold therapy, that will help in the uh, that will help the ciliary body, that will help the ciliary body to get necrosed, and thus reducing the aqueous humor production. That is your cyclotherapy. Cyclocryotherapy normally uses liquid nitrogen. And the other one is your laser cyclophotocoagulation. So with this, the laser is being used to hit the ciliary body, because of which there will be the destruction of the ciliary body, resulting in the ciliary body process, that again helps in the less production of the aqueous humor. So these are the surgeries which are used normally for the therapy of surgical therapy for glaucoma. And but however, like, you, instead of using either of the surgery, it has been found that both the surgery, when used together, it's more effective. And finally, eyes that are irreversibly blind from glaucoma are better treated surgically through evisceration and intraocular prosthesis or enucleation. Another emergency ophthalmic condition in pets we see is acute anterior uveitis. This one also needs urgent treatment. Uveitis is extremely painful. It's associated with life-threatening systemic disorders. There is permanent structural lesions may result in blinding consequences. Example: secondary glaucoma and cataract. And the emergency treatment to be followed after proper diagnosis. So secondary glaucoma, whenever there is it's often seen during the lens luxation. So luxation of the lens there is the when there is the when there is the luxation of the lens, there is the painful condition of the eye, and intraocular pressure it increases because of the disruption in the balance of the inner eye liquids. So acute anterior lens luxation, this one is the another ophthalmic emergencies. The reason is it's painful, leads to glaucoma. There is uveitis, this corneal edema and retinal detachment. The severe corneal edema and blepharospasm sometimes makes difficult to identify the lens luxation. So for this, we need to go with the ultrasonography. Secondary glaucoma, like I said, caused by the obstruction of the pupil by the lens or vitreous, can be rapidly blinding and must be immediately addressed. Pupil block and elevated IOP, intraocular pressure, accompanies anterior lens luxation. Phacoemulsification with capsular tension rings placed to increase lens stability, intracapsular lens extraction techniques, partial anterior vitrectomy reducing the risk of anterior vitreous movement, or the placement of the intraocular lens fixed by sutures. So as we see in the picture on the on the left side of the screen, there's the anterior lens luxation. These are all secondary to the glaucoma. And the other one is the primary acute lens luxation, and the third one is the secondary to the chronic uveitis. Second, acute anterior lens luxation, that is secondary to the chronic uveitis. Sudden blindness requires immediate veterinary attention. A complete history and ocular examination are necessary. Differential diagnosis includes the following two main conditions: the ingrossed episclera and conjunctival blood vessels. If there is the ingrossed episclera and the conjunctival blood vessels seen, then that could be acute glaucoma, acute uveitis, or retinal detachment. So that is one condition when we can say when the pet usually loses their vision. And the second one is the normal episcleral and conjunctival vessels, that is blind but quiet eyes. And the other condition we often see is there is the optic neuritis. There is sudden acquired retinal degeneration syndromes in dogs. These are mostly seen in the retrievers. After epileptic seizure also, we find animal goes blind. Various toxicities with the use of topical endectocides, ivermectins, enrofloxacin in felines, the pets, permethrin, end-stage progressive retinal degeneration, acute onset of cataract in diabetes mellitus, retinal or vitreous hemorrhage, inflammatory disorders of the central visual pathways, cerebral hypoxia after general anesthesia for routine procedures. So all these conditions, all these factors all these situations are responsible for the sudden blindness in the pet, which needs to be immediately addressed. So first and immediate management is the golden rule is to handle gently, protect and lubricate, avoid storage in ulcers. Emergency drugs needs to be kept in the clinic. Like we see there are a lot of drugs, eye drugs we see, like for Ferdex, which is the steroid, which will be very helpful in the inflammatory condition of our eye. And we have some artificial tear, artificial eye gel, artificial eye gel we can say, like there is for fresh gel, and also some emergency antibiotics for lot M with lopridine and moxifloxacin, or for lot T, for tobramycin. So all these emergency medicines, eye medicines, needs to be kept in the clinic, which are required in times of an emergency. So temporary measures until reference. So we can use all these medicines, whichever I've said just now, like Ferdex or for Top, for Lot M, for Fresh Gel, for Queen. So there are so many eye medicines which we need to keep in the clinic in times of an emergency until we refer it to the specialist or the veterinary ophthalmologist. So do's and don'ts in emergencies: start lubricants. Whenever we see an eye situation, then we have to lubricate the eye, keeping it moist, so that the corneal layer is not damaged. And also start with the antibiotic therapy as soon as possible. Pain management is key, because I've already said cornea, it is very sensitive. It has like 300 to 600 of the nerve supplies in the cornea, which is very high compared to the skin. So pain management is key. Never use topical steroids in ulcer. Whenever there is ulcer, corneal ulcer, also like condition, then we should not use steroids, and we should not delay in referring the vision threatening cases to the specialist. So emergency flowchart: assess the vision and pain, assess determination of the vision we can do with the use of different reflexes, like we have already talked about the Minens, Dazzle, palpebral reflexes. And if there is any pain, we have to manage it. Identify emergency type. So we have to see the which one is the emergency cases that has to be addressed as soon as possible. Stabilize with the use of medicines, lubricants, pain relief, and sometimes even anesthetics. And then finally, you have to decide whether you go with the treatment or you have to refer it to the specialist. So these are the basic diagnostic tools every vet should have: torchlight ophthalmoscope, magnifying loop, shimmer test strip or fluorescent strips, tonometer, tonopen or tonovet to detect the IOP, sterile eye wash, cultural swabs and media, glass microscope slides, 15 scalpel blades, needles 20 to 27 gauge, emergency eye medicines like topical anesthetics, excuse me, topical anesthetics, atropine, mannitol, prostaglandin analog steroids, tear replacement solutions, neomycin, bacitracin, some of the topical antibiotics and ointment, and systemic antibiotics and anti-inflammatories as well. So prevention and client education, we always have to motivate our client to bring their pets for regular eye checkup, especially in brachycephalic dogs and those which are predisposed to predisposed breeds to different hereditary eye conditions. Owner awareness is very, very important. Certain signs that needs urgent vet visit. This has to be told to the owner. Grooming and hygiene tips: how we need to groom and what are the different hygiene tips, or like whenever we are taking care of an animal, like how to bath them, how to groom them, so that their vital organs are not affected. So these tips needs to be shared with the owners. So the key take home message, I would say, examine eyes systematically. So from outside to inside, we have to examine eye, recognize the red flag emergencies. What are the red flag emergencies that needs vet, immediate ophthalmologist, vet ophthalmologist, like deep corneal ulcer, or your lens luxation, anterior lens luxation, uveitis, or proptosis. So all this red flag emergencies needs to be addressed. We need to act fast, because the more time we take in treating the animal, then there is high chance that the animal will lose its vision. We need to stabilize, and referral is important whenever needed. Early intervention always saves vision. So with this, I would like to end my um, talk over the pet anatomy and the emergencies. Thank you.
Um, Thank you, Dr. Samir, for a very wonderful and a clear presentation. It was very enlightening. Thank you for your time and knowledge. Next, moving forward to
Doctor,
the...
can you stop the presentation, please? Thank you.
Oh,
Sure.
sure, sir. So next, moving forward with the question round, um, I would I would like to call upon all the speaker, all the panelists, Dr. Pandey, Dr. Sudrenla, and Dr. Samirda. Um, so the first question that I would like Dr. Samir to answer is, which anatomical structures in eye are the most vulnerable to any sort of trauma in field practice, either in clinics or anywhere else? So the floor is yours.
So during my talk, I've already said a cornea. It lies it's the outermost portion of the eye, which are very susceptible to any kind of infection, any kind of trauma. So obviously, cornea, the corneal damage or corneal trauma is very often seen in the field. And apart from that, we can also say, like, it depends on the type of trauma. What kind of a trauma the animal has undergone. Like, it could be blunt trauma, it could be perforating, penetrating trauma. So in terms of blunt trauma, we see the eyeball as a whole is more affected. There is the displacement of the eyeball from the orbit. Sometimes, like we see in proptosis, there is the damage of the UAM, that is extraocular muscles, gets damaged, the sclera gets damaged. So so that is like mostly we see in the blunt trauma. And sometimes also the interior of the eye, like the lens and the iris, they are also affected by the blunt trauma. But when we talk about the perforating or the penetrating trauma, then the cornea and the interior of the eye are more damaged. So I would say the perforating or the penetrating trauma, they are more likely to create severe damage, like corneal laceration, or sometimes there is, like, the lens luxation, there is the retinal detachment. So all this gives a very poor prognosis. Thank you.
Dr. Samir, I would also like to add two structures basically. One would be the eyelid and the third eyelid. So, we often come across cases where, dogs or cats end up fighting with each other. So there are scratches, abrasions, etc. also, so that uh, before, most of the cases, what I've seen is, there are affections of the third eyelid and as well as the eyelid as a whole. And then, the cornea follows. Yeah.
Exactly, exactly.
Yeah.
Thank you so much, Dr. Pandey and Dr. Samir Chetri. It was very informative, and I'm very sure that in our day-to-day practice, we will really use this information. Thank you so much. So the next question, I would like to invite our panelists for today, Dr. Sudenla Bhutia, to give her insight in this next question. What are the first signs of ocular emergencies that owners may miss in any sort of clinical emergency? Yes, ma'am. So the virtual floor is yours. Ma'am, you're actually not audible. Oh, Shami.
Yeah. So the first symptoms, visible symptom would be the pain. So the animal would be in discomfort. And with that, we would see discharge. So the discharge may be a clear discharge or discharge which are yellow in color or green in color. And there may be repeated blinking of both the eyes or one eye. And there may be powing of the eyes, there's irritation. Or the eyelashes, there may be irritation due to the eyelashes. And there could be an insect bite. which leads to the swelling of the eye or the orbit of the eye. And there may be cloudy eye. There may be vision loss also, where the owners miss it, say suppose your pet is not able to find a direction, or they are banging themselves, and at times the owners, they miss these signs, and we say like are lag gaya, or he's not being able to move, but it could be due to a partial or a full vision loss as well. And along with that, I guess there'll be redness. And suppose if there's a blunt injury, so blood accumulation in between the cornea and the iris, that is known as hyphema, I guess that would also be one of the signs. Yeah. Yes, no?
Yes, ma'am. Thank you so much, ma'am. Thank you so much for your views in this. It was very refreshing and enlightening. Moving forward, a solo question to Dr. Pandey, and I would like Dr. Samir or Dr. Sujan Labutia to add more their views later on. So the next question that I would like to ask Dr. Pandey is, how quickly during any emergency conditions can we differentiate between a conjunctivitis and a corneal ulcer in practice? The floor is yours.
Okay. Yeah. So in case of corneal ulcers, I think we should look into the cloudiness part of the cornea. So if the cornea appears cloudy, probably you would have to go for a dye test, and once you go for a dye test, the ulcerated area would stain. So that way you could probably differentiate between conjunctivitis and corneal ulcer. Whereas in whereas in conjunctivitis, redness in the eye, redness of the conjunctiva, and there might be swelling. So these are probably the two differentiations that would be for corneal ulcer and conjunctivitis.
Thank you so much, sir.
And so also, I think to this I would like to add, Dr. Pandey, I think in corneal ulcer, since there is the disruption in the vision, because there is the cloudiness of the cornea,
Yeah.
there is obvious disruption in the vision. So I think the animal won't be able to respond to any of the reflexes, like the common
Agreed.
Menin's reflex, we can say, right? Or the Menin's reflex, I think I would say Menin's or the pupillary light reflex. So the animal will not respond to that reflex. Whereas in conjunctiva, since the cornea is intact and there is no damage of the cornea, so the animal will be able to respond to the Menin's reflex. And also the dye, use of the dye, fluorescent dye, the corneal ulcer will be able to hold the dye, but it's not obvious in the eye with conjunctivitis.
I guess in conjunctivitis, we use this rose Bengal dye test as well. No? So the fluorescent dye test would be for the corneal ulcer, and I guess the Bengal dye test would be for conjunctivitis. Basically, that would be loss of the epithelial cells that will take the stains, so that the stains visible in the fluorescent dye test.
Okay.
Thank you, ma'am. Thank you, sir. So here there is a few questions here in the comment section by the audience also. So just two more questions that I would like to ask. So yeah, so the first question here is, okay, so specifically, there is a question here by Ananta Shah, a fourth year BVC and AH student. So his question here is, which medications are safe for initial emergency use before any surgeries? In any sort of, let's say, emergency cases. So the first medicines, let's just say it can be antibiotic or any lotion. So the platform is open for anybody to answer this.
I think steroid is very important. We need to keep that in hand always. Like I said, we have this Ferdec dexamethasone eye drop for Entod. Steroids very important, provided the animal is not having any ulceration. The topical application of steroid is very helpful in majority of the eye cases. Mostly we see in emergencies, like whenever there is this uveitis, there is this hyphema, or whenever there is the inflammatory condition with the proptosis, right? So the trauma of the eye. So steroids, I think it should be available all time. And the second one, atropine sulfate, it has got this effect on the lens and the pupil, and it has got this, like, dilating the pupil, and, like, controlling the spasm of the ciliary body. So this atropine availability, I think it's important in clinics. And apart from that, obviously, topical antibiotics is very, very important. Of course, culturing is important. The cytology is important, giving any antibiotic, but like in field conditions, sometimes we are devoid of those facilities. So this topical antibiotics, like for top we have we have for lot M, or this for queen gel. So these antibiotics, like, moxifloxacin, tobramycin, so these range of topical antibiotics, I think, would be helpful in any kind of situation.
So basically, I guess the first need would be lubrication. So the first would be lubrication. So for that, we have products from Entod Pharma as well. We have Fresh. So anything with carboxymethyl cellulose, or we have polyvinyl alcohol with povidone. So these are the first basically you lubricate the eye, and then after, your diagnosis can follow whether there's bacterial infection, or it's a trauma case, or it is an parasitic case, whatever. Then after that, I guess what Dr. Samir has added, after that, I guess the treatment can be done.
Okay.
Right.
Thank you, ma'am. Is there, Dr. Pandey, I would like to request you to add any more points if you would like to in this particular topic.
No, I think most of it has been covered by Dr. Samir and Dr. Sudhin.
So there are many questions here in the audience section, and I'm sure if we had even more time, we could answer all the questions. But with the time limitations, I guess this will be the end of the question and answer round. And yeah, thanking everybody, all the panelists, the speaker, even the audiences that are here. And with this, we come to an end for this webinars, for today's webinar. And again, a very big thank you to everybody, to the audience for the participation and their patience, and wishing everybody a great evening, and looking forward to many more seminars in the coming future. And in this short duration, I hope this was a success, and thank you so much.
Thank you, Noam.
Thank you.
Thank you, sir. Thank you.
Thank you, doctors. Thank you.
Thank you, Vishal.